next topic would be mine, sphenopalatine ganglion block. Okay. I'm so sorry. I'm boring you repeatedly. So now the sphenopalatine ganglion block, it's a simple block done for orofacial pain. Now for me, orofacial pain was not such a big identity because most of our pain practice is restricted to spine and joints and everything. And very recently, around 2 or 3 years back, I was invited by one of our leading ENT specialists from Meerut. And I said, sir, I have 2-3 case type के होते हैं, कहता तू आ तो. And then he called me, and that was the real time where I found a lot of patients coming with varied presentations of various orofacial pain. That is one. Second thing, as we famously or infamously were discussing about the various complications post-surgery where the patient continues to have pain. In the same way, what the ENT surgeons suffer is that sometimes they do a surgery like a simple mastectomy or ethmoidal or sinus surgery, and the patient comes to with a lot of orofacial pain, which they are sometimes not able to understand. And along with that, those set of patients also have symptoms which are suggestive of sympathetic or parasympathetic overactivity. So in those subset of patients, this block or these kind of blocks can really help us. So with that background, let us start. So where are we doing this sphenopalatine ganglion block? Don't worry, you can text me, you can have my this presentation, nothing great. I have not reached to that level where I do something very great, but you can have it. Cluster headache, atypical headaches, sphenopalatine neuralgias, CRPS, neuralgias of the face, and sometimes in cases of orofacial cancer. Everything starts with the anatomy. This ganglion is present in the fossa. The fossa is present in the pterygoid process and the sinus. The lateral opening is the pterygomaxillary fissure. The medially we have a palatine bone. There's also an opening, interestingly, in the nasal cavity to the sphenopalatine foramen. So basically, for us, we can enter this space either externally or even through the intranasal route. Or a more important thing, the sphenopalatine ganglion is located in the superior 1/3. So when we are trying to do an intervention of this of the ganglion, we always try to target the upper 1/3 of the ganglion. So now this is the famous reverse triangle. So this is the space that we need to target. Even in fluoroscopy, when you will be I'll be sharing the images, this is the reverse flask thing that we need to target. That is one. Second, regarding the complications, so any structure which is present here, right from zygomatic nerve, the infravital, alveolar, lesser palatine, greater palatine, all these nerves along with the arteries are the ones which can be damaged if we are not careful during the procedure. Now, how do we do it? First is, and the easiest thing is the intranasal approach. Classically, patient of cluster headaches comes to us, severe headache, which is very cyclic, and sometimes the patient even cannot come to the hospital before it subsides. So what do? Or if the patient comes to us, obviously we give oxygen, and then we go for a sphenopalatine ganglion block through an intranasal approach. The point is to get the local anesthetic in the fossa. So what we do is we just introduce local anesthetic. Now this can be done by a pedette, this can be done by a syringe, this can even be done, what I was taught and what I think was we just soak a gauze piece in local anesthetic, ask the patient to have an extended neck, put it in, place it for 5-10 minutes, patient is comfortable, the pain settles down. This is something that we even tell the patient that this is something like a first aid that we can do it at home also. Only precaution is that we ask them to keep a liberal part of the gauze piece outside so that they can pull it out. But sometimes what happens is, now that is for cluster headache, sometimes the pain either doesn't subside or there are atypical presentations of this kind of patient with severe burning, itching in the facial region, or the patient has repeated attacks which are responding to these sphenopalatine ganglion blocks, but they have a tendency of coming back. In that, we can consider going for a diagnostic block. So before that, just see again, as a trigeminal ganglion block, the sphenopalatine ganglion block is what I call it is a technician's block. So for example, if you can get this image, your job is done. You just need to introduce the needle in this position. But sir, but if you are not able to appreciate this, you can never do it, because this is a very narrow space and there is a lot of overlapping. So how do we do that? Now here the patient is lying supine. Second, the position of the Siam is going to be lateral. Now the challenge, as I said in my previous talk when I talked about fluoro anatomy, was getting a perfect AP. In this, getting a perfect lateral is a challenge. We really want the right and the left to superimpose to give us one image. Now there are various ways. So some people talk about concentrating on the eardrum so that you get the eardrum. Some talk about mastoid, but some simple trick which one of my teachers told me was that ask the patient to put up a stethoscope. So ask them to put up a stethoscope, ask them to hear their heartbeat. They are also relaxed, and you just need to align the stethoscope. So now that becomes, because that's a huge thing, so you just need to get a perfect lateral image where the stethoscope is matching. You will get this image, and you just need to introduce it from lateral to medial. Now this is what I was talking about. You get a lateral image, this inverse was appearance, and then this is the lateral image. Now this is again because this palatine bone is very small and fragile. Therefore, once I am inside the foramen, I get that feeling that I have entered the fossa. I make the patient, my Siam AP, excuse me, I get the Siam in AP and introduces gradually, making sure that I do not puncture, because this bone, palatine bone, is soft, and even with a 22 gauge spinal needle, there is a possibility that you might pierce it. Lateral, as I talked about, perpendicular, yeah. So positioning, it has to be supine, lateral view, rotate the head to get a true lateral view. So you can take any structure, as I told you, the eardrum, the mastoid, or try the stethoscope. Enter point is inferior to the zygomatic arch, just in front of the coronoid process. Now this is something, again, sometimes people struggle because in a closed mandible, you cannot go in front of the coronoid and it is blocking. So sometimes you even have to ask the patient to open their mouth. So the moment they open their mouth slightly, that also makes our job easy, and we are able to identify the VAWS. So what people who are starting, please take these small tips, utilize it, and do not try to introduce before seeing the VAWS, otherwise you might struggle. AP view, lateral valve, we have already few tips which I have found is perfect lateral image is something which holds the key for the procedure. One can move the coronoid process, just ask the patient to open the mouth slightly, and then your thing, that is second. Third thing, which I was even discussing with doctors who were there with me in the OT, as a beginner, there is no harm in bending the tip so that you are oriented when you are introducing it, especially in fluoroscopy. So that bend tip gives you an idea about orientation, that is one. Secondly, don't target the fissure or the any foramen, try to target the bone. Go close to the bone, hit the bone, be rest assured, and then redirect and go in. So that is the 3 things. Regarding the RFA, so firstly we go for a diagnostic block. If the patient has relief, then we go ahead with a radiofrequency ablation. So ideally the tingling sensation should be at the tip of the nose. Excuse me. But if the tingling sensation is in the teeth, it means that you are too anterior. Right? So ideally it has to be at the tip of the nose, but if it is anterior, you just like to pull it, redirect it posterior side to make it slightly posterior. If the tingling is at the palate, it means that you are down, you need to move more cranial. So these are the small tips and tricks which I will request, and thank you so much.
Now only 1 or 2 questions, anybody? We are already half an hour late.